All right. I'm gonna sneeze. Oof. Whew. All right. All right, let me share my screen with the schedule. We're getting there. Um, so far we've done a lot of chapters. Up to 22. Tonight we're doing 23 environmental emergencies, 24 OB and neonatal care, and chapter 25 is pediatric, and then we just have 2 chapters each night left. And then on your own, August 10th, that NIMS 700. If you haven't gotten me the 100 or send it to Jules, please do that. We need to keep copies of those. So I've gotten a few of them, but make sure you hop on there and get that done. All right. I'm assuming that's Denise that just hopped on. I don't know if there's a Dennis in this class, but we'll go with Denise, it looks like. All right. Let me share again and we'll get going with chapter 23. All right, so chapter 23 is environmental emergencies. So for environmental emergencies, we're going to talk about temperature regulation, cold emergencies, local cold emergencies, heat emergencies, and submersion emergencies. And remember, this is very basic. Anything more than this would be like, for especially submersion, would be like water rescue, that type of thing. So as a first responder, we're going to be called to respond to a lot of different types of emergencies, and some are resulting from heat and cold, as you can imagine, where we live in Minnesota. Um, Today would be heat emergencies because it's like 90 degrees outside, but in the winter, obviously, on other parts of the time of year, it's cold. Safety always comes first with us, like we always have been saying. Remember that we are going to be exposed to the same conditions that the patient is being exposed to, so make sure that you're taking precautions to prevent yourself from also becoming hyperthermic or hypothermic. So our role is to assess and provide emergency care to those suffering from environmental emergencies. That's what we're going to talk about throughout this chapter. So temperature regulation. We have to maintain a normal body temperature in order to continue functioning properly. So the body produces heat through what we call metabolism. It regulates temperature by shivering and by dilating and constricting peripheral blood vessels. Heat is lost through convection, conduction, radiation, evaporation, respiration. We'll have a picture coming up. We'll talk about those. So metabolism, that's our normal process of regulation, by which our body regulates our temperature by producing and conserving heat. Metabolism includes all the physical and chemical changes that occur in the body. This process is controlled by our hypothalamus in the brain. The hypothalamus acts like our body's thermostat, essentially. It maintains a normal body temperature of 98.6 degrees Fahrenheit. And some people are a little lower, some people are a little higher. And we use degrees Celsius a lot in EMS, like on our temperature, our thermometers and that type of stuff. So 37 is kind of the 98.6 that we're looking for. Anything above that would have a temperature. So when the body is exposed to cold temperatures, it retains body heat by responding in a few different ways. It's going to constrict the blood vessels in the skin, and it's going to shunt the blood inward and keeps it from being exposed to the cold temperatures of the skin. So it's going to shunt it from away here towards our core. The erection of the hair of the body thickens the layers of warm air trapped at the skin surface. That's where the hair raising comes from. If needed, the body can also begin shivering, which produces body heat through contraction of our muscles. And the body may produce hormones like epinephrine, so epi, to generate heat by increasing our metabolism. So when the body is exposed to hot temperatures, it dilates the blood vessels in the skin, allowing for heat to be eliminated. And we'll talk about that. And this is different ways heat can be eliminated. So our temperature regulation, we can lose heat in these ways. We can lose heat through convection. This occurs when air passes over the body and carries heat away from the skin surface. This would be like fanning somebody off. We have conduction on the bottom right there. Occurs when direct contact with an object carries heat away from the body. Submersion in a liquid causes a much faster transfer of body heat. We lose heat 25 times faster in the water than we do with just air. Radiation, this involves the transfer of heat from an object without direct contact. So our bodies are constantly radiating heat in order to maintain a normal body temperature. Most body heat is lost through radiation from the head and the neck areas of the body. That's why people like to have a hat on. When newborns are born, we like to put a cap on them. We have evaporation. This is the process by which sweat changes to vapor. As sweat evaporates off of our skin surface, heat is carried away with it. Once relative humidity reaches 75%, that stops. So checking the temperature outside. If it's 75% humidity, we're not really going to do that. Respiration, this occurs when we breathe in cool air and we breathe out the air that has been warmed by our body. So like we breathe out that hot air, that's the respiration part of it. So when we talk about cold emergencies, generalized cold injuries, these are influenced by risk factors, including the patient's underlying medical condition, their age, medications they might be taking. When we're assessing cold injuries, we want to consider scene size up and the mechanism of injury. Prioritizing, treating generalized cold injuries, just gonna get them dry, get them out of that environment, passive rewarming, and then we'll talk about when assessing severe hypothermic patients. So these cold emergencies come in two major groups: generalized cold injury or hypothermia, which is kind of all over your body in general, and then local cold injuries, which is frostbite. So when we're exposed to cold environments, we can be negatively affected in a couple different ways. Generalized cold injury or hypothermia, this affects the entire body, or the local is more a specific portion of our body. So keep in mind that these two types of injuries can present at the same time. You can have frostbite and be hypothermic. So for the generalized cold emergencies, a patient can suffer from hypothermia by being exposed to extreme colds for a short period of time, or by being exposed to a moderately cold environment for an extended period of time, more chronic than acute. Several risk factors predispose a patient to suffering hypothermia: underlying medical conditions or trauma. So people that are diabetic, they have an infection or circulatory problems. Use of drugs or alcohol or exposure to some poisons can be risk factors, and the patient's age. The very young and the elderly are more at risk for becoming hypothermic. Infants are at a higher risk of becoming hypothermic because their head is proportionately larger than their body, which is why we like to keep kids warm and keep their heads wrapped up. The body loses heat anytime the ambient temperature is lower than the body temperature, so it does not have to be extremely cold for a patient to become hypothermic. So a scenario that they give, a few young people have been drinking alcohol while driving down the highway. The driver swerves to avoid hitting an animal and loses control of the vehicle. They drive into a pond. It's 76 degrees Fahrenheit outside with a light breeze, and the water temperature is 72 degrees Fahrenheit. Factors that are pertinent in that situation are water, right? We lose body temperature 25 times faster in water, especially moving water. 72 degrees and 76 degrees, that is technically lower than our 98.6. It seems warm out, but when we're in there for an extended period of time, we can get hypothermic that way. So for these patients, we want to do a scene size up is an important part of the patient assessment. As we approach the patient, asking ourselves some questions. Does the environment suggest the possibility of hypothermia? If so, is the patient still located in that cold environment? So we need to move them, get them out of that environment. Is the patient wet? We need to get the wet clothes off and put something dry on them. And how long were they exposed to the cold? Have they been out there for 20 minutes? Have they been out there for 5 minutes? Have they been out there for 12 hours? Maybe they slipped and fell last night and nobody found them. Stuff like that. So questions we can ask. Signs and symptoms of hypothermia. So hypothermia is a progressive condition. Patient's condition is going to deteriorate without proper intervention. When we approach the patient, we're going to feel the patient's abdomen to assess whether it's cool or cold to the touch. If it is, we're going to treat them for hypothermia. Like our abdominal area or our core, if that's cold, they're pre-hypothermic. It represents the patient's body temperature at the core, not our extremities. So we want to feel up into their abdominal area and see if that's cool or cold. One of the first mechanisms the body uses to generate body heat is shivering. This is a mechanism that eventually is going to stop if the patient remains in that cold environment. Once the patient stops shivering, they may appear to be clumsy or confused, start having that lack of coordination. The patient may begin to exhibit a decrease in responsiveness, confusion, making poor judgments. It's pretty common findings. As time goes on, the patient becomes less communicative and more difficult to wake up or arouse. The patient begins to exhibit joint and muscle stiffness and rigid posture, making them less mobile. It's hard for them to walk or stand up or move any joints. As body temperature continues to fall, the body continues to shunt blood away from the skin. The heart rate begins to decrease, and the patient may become unresponsive and appear to be dead. So these patients require immediate treatment and transport in order to survive. So that's our assessment, signs and symptoms under our sample. Our generalized, what do we do for this? For care, we assess the scene and take appropriate precautions. If you're not wearing a jacket, put one of those on, especially if it's -40. Activate EMS, notify them of the situation. Immediately remove the patient from that cold environment if possible. Don't allow them to sit or lay directly on the ground because they're just going to keep getting colder from the ground, from conduction. The patient will continue to lose body heat from that. So if indicated, provide warm and humidified oxygen to the patient. If the patient's clothing is wet, remove it, cover them with a blanket, keep them warm. Handle the patient gently. We're not going to massage the extremities. We're not going to let the patient walk or exert themselves or let the patient eat or drink stimulants. We don't want to give them any pop or any coffee, anything like that. We can give them warm fluids, but as long as they can swallow, but nothing that has caffeine or anything like that. Monitor the patient's vital signs. We may need to take additional time to assess the pulse and respiratory rates. This is where I've told you guys to assess for like 30 seconds. This is where I would take that full minute to get a pulse because they might have a pulse of 12 or 16. They might have a respiratory rate of 6 or 8. Be calm and reassure the patient if they are awake. The categories of hypothermia, not that we all carry thermometers out there, and there are types of thermometers that are hypothermic thermometers that go down to these levels. A lot of times ours will just say cold if it's too low. So the degree of hypothermia is determined by core body temperature measurement. So mild would be 90 to 95 degrees Fahrenheit. Remember, 98.6 is kind of normal. Moderate is 82 to 90, and then severe hypothermic is less than 82 degrees Fahrenheit. In most cases, we don't have the proper equipment to measure that exact number, but we can rely on the patient's signs and symptoms to determine kind of where they're at, and I'll talk about what some of those are coming up. By assessing and observing the patient, we're going to be able to differentiate between mild and severe hypothermia. So with mild hypothermia, they have an increased breathing rate, an increased pulse rate, and an increased blood pressure. So all their vital signs are going to be increased. It is a progressive condition, like we said earlier. So recognizing these is kind of important to know kind of where they're at. They're going to have a slow, thick speech. They might be staggering or have an unsteady walk. They might be apathetic, drowsy, or incoherent. Check their pupils. We're always looking for pearl, right? Pupils equal and reactive to light. They might come back a little sluggish. And then uncontrollable shivering. Now, they're still in mild hypothermia if they're shivering. For these folks, if the patient is still alert and orientated, we want to allow them to drink warm fluids. Don't allow a patient who is lethargic, if they can't maintain their airway, to drink anything. We have to make sure they can protect their airway. They're going to aspirate on those fluids. Don't give them coffee, tea, cola, anything that's caffeinated or a stimulant. It's going to promote heat loss. So warm water, something warm but not caffeinated. In order to prevent further heat loss, cover the patient with a warm blanket, making sure that the head, neck are all well covered. If heat packs are available, we're going to apply them to the neck, the armpits, and the groin. Large blood vessels close to the skin surface in these areas can help warm the blood as it runs through the area. So neck, armpits, and groin where our big vessels are. If somebody has severe hypothermia, they've switched from mild into severe, patient could be unresponsive. which are their signs and symptoms are going to be very unstable. Severe hypothermia is a true medical emergency that can lead to death for these patients. So if we see extremely slow breathing, extremely slow heart rates, if they're unresponsive, fixed and dilated pupils, they might have rigid extremities, stiff. They're not going to be shivering anymore. We would want to maintain their ABCs. So remember that when a patient is unresponsive, they're not able to maintain their airway. So we would have to open their airway with a head tilt chin lift or jaw thrust, and we would have to put an adjunct in, which would be an oral airway or a nasal airway. So that would maintain their open airway. Administer high flow oxygen by a non-rebreather if their breathing is adequate. Ventilate with a bag valve mask attached to high flow oxygen if their breathing is not adequate. So if they're breathing at a rate of like 6, we want to get the bag valve mask out. When assessing for a pulse, we're going to take additional time for assessment because the possibility of a very slow heart rate and a very slow respiratory rate is possible. Pulses may not be felt at the extremities, so we want to check the carotid pulse and the neck. If there's no carotid pulse after 1 minute, we're going to start CPR because we always say a patient isn't dead until they're warm and dead. Resuscitation of the patient until the body temperature has been returned to normal in a hospital setting is what is our goal for these patients. We want to handle the patient gently. Rough handling of severely hypothermic patients who have a pulse and is breathing could lead them to ventricular fibrillation and sudden cardiac death. So we want to just make sure we're not jostling them around too much and moving them slowly and handling them very gently. Rewarming a severely hypothermic patient in the field is not recommended. The patient needs special medical care and should be transported rapidly to the hospital where they can get them in there. They're going to put them in a bear hugger, pump in warm air. They might do a lavage through the abdominal area with warm fluids. There's ways that they can warm these patients up, but we're always going to start CPR on somebody with hypothermia because they're not dead until they're warm and dead, till they get back to that core body temperature. You'd be surprised how long people can stay alive when they're hypothermic. Local cold emergencies, so frostbite. This is when it just affects a particular part of our body or parts of our body. These injuries can also be superficial or they can be deep, kind of like burns. Signs of a localized cold injury, also known as frostbite, include a change in skin color, loss of sensation, or blisters. The goal of care for the patient with a localized cold injury is to prevent further heat loss and improve circulation to the injured body part. We can consider rewarming a localized cold injury only if transport is delayed and there's no chance that that part is going to refreeze. So we're never going to rewarm an area that has late or deep frostbite. We're going to bring them to the hospital. We can start an area that has light frostbite, but not deep frostbite. So these are kind of considered like burn injuries. So there's early or superficial local cold. So these cold exposures can affect parts of the body that are not well protected from the environment. Usually our face, our nose, ears, hands, fingers, feet, and toes are the most commonly affected body parts. So when a body part is exposed to the cold, the blood vessels actually constrict, which reduces circulation. And our body is made of water, right? So ice crystals form in the tissue since our body is 60% water. In severe cases, gangrene can set in as a result in the loss of a body part. Like generalized cold emergencies, local cold can be classified into 2 categories. So we have early or superficial, and we have late or deep local cold injuries. Each category has specific signs and symptoms that allow us to differentiate this. So signs and symptoms of late or deep, usually it's like a waxy skin. When the skin begins to freeze, it takes on a waxy appearance. It's going to be firm to the touch. When the skin is palpated, it's firm or hard when you touch it. It could be mottled. The skin takes on a mottled or blotchy kind of coloration. Swollen, blistered, and white. So our skin is, or our body is 60% water, so it begins to freeze in cold temperatures. Water, when it freezes, it expands, right? Which produces that swelling and blistering of the skin. The skin also takes on a white coloration during that time. So that type of injury is called frostbite. With superficial, so this one is just kind of, it's not as bad as the deep. So discoloration of the skin, If you have light-skinned patients, usually lightly colored skin will redden. And if you have darker skinned patients, darker colored skin, it will start to get a little bit pale. When the skin is depressed gently, it's not going to blanch and return to normal color. This is caused by the constriction of that blood vessels and reducing circulation to the skin. So this is where we would do like a cap refill, but like push on the part that's not hard, but push on the part that is frostbit to see if that comes back. Patients will also have a loss of feeling or sensation to that exposed part. I'm sure we've all experienced a little bit of this in our lives. So we're going to assess the scene, take appropriate precautions. We want to activate EMS and notify them of the situation. We want to immediately remove the patient from the cold environment if possible. We're not going to allow the patient to sit or lie directly on the ground because we're going to lose body heat through conduction. We're not going to allow the patient to walk on a frostbitten limb. So if it's affecting their feet or their legs, we're not walking them out anywhere. We're going to carry them. Remove any wet clothing, protect the area from further injury. If possible, remove jewelry and constricting bands, which could hinder circulation when the tissue starts to swell. We're not going to rub or massage the injured area. This is going to damage the fragile tissues and capillaries and produce actually further injury to the patient. We're going to calm them, reassure them, monitor the patient's vital signs, document your findings, and pass information along to the ambulance as they're coming in. For the rewarming part, we can only consider rewarming for certain situations. If transport of the patient is going to be delayed, we can consider rewarming the injured area. We're never going to rewarm late or deep injury. So if it's really bad frostbite, don't even start rewarming that. And we're only going to rewarm if there's not a chance that's going to refreeze. So if we got them out of that environment into somewhere warm, we could do this. I don't know how you would do this in an ambulance, honestly, because to do this, you would want to use a container large enough to rewarm the entire area at the same time. Tepid water around 100 to 105 degrees Fahrenheit. We're not going to allow the injured area to come in contact with the bottom or sides of the container during rewarming. And during the rewarming process, the patient may complain of tingling and pain in the injured area. It's going to hurt when they start coming out of this. Tylenol, that kind of thing for local protocol. But a lot of times if this is happening, you might also want to consider ALS, especially if you do start to rewarm an area because it's going to be painful. Once the area has been rewarmed, we're going to wrap the fragile tissue with dry, sterile gauze. So treat it like a burn. We're going to wrap this with dry, sterile gauze. If the injury includes the fingers and the toes, we want to place something between them before we consider wrapping it. And then we can consider applying a bulky dressing for padding over top of it so it's not bumping into things. This is that video I had you guys watch. Hopefully you did that. All right. Cold. Heat emergencies. So when a person cannot lose excessive heat, heat-related emergencies often develop. In severe cases left untreated, the body can lose its ability to control body temperature, and the patient may develop an uncontrolled rise in body temperature. The increased in temperature, this is called hyperthermia, which can actually lead to organ damage and death. The three major heat-related conditions are heat exhaustion, heat cramps, and heat stroke. The body's ability to respond to the heat challenges is affected by a variety of factors, including ambient temperature, humidity, medications, age, underlying medical conditions, very similar to cold. Signs of a heat emergency include weakness, muscle cramps, rapid pulse rate, dizziness, fainting, headache, altered mental status, seizures. There's a ton of them. We'll go through them as we come up here. So when a person cannot eliminate excessive heat, it accumulates in the body and results in hyperthermia. Three different classifications of heat-related emergencies are these. So you have heat exhaustion. This is a result from a mild state of hypoperfusion, or also known as shock, right? Hypoperfused, not getting enough oxygen to those areas of the body that needs it. Strenuous work in a hot, humid environment can lead to excessive sweating and fluid loss, and that can result in hypoperfusion. Heat cramps. This involves spasms of the muscles of the legs, the arms, and the abdomen typically. This occurs when electrolytes like our sodium and our potassium are lost during profuse sweating. This is why we like to have them drink like Gatorade or some kind of energy drink, or not energy drink, but some kind of drink like Powerade or Gatorade. Heat stroke. This is a life-threatening condition when the body overheats and often stops sweating. If left untreated with this one, brain cells die, resulting in permanent disability and death. So if we can catch the heat exhaustion, that will then lead to heat. That won't lead to heat cramps. But if we're not catching this stuff, we're eventually going to have heat stroke if we don't get them out of that environment. Contributing factors. So ambient temperature, a high temperature reduces the ability of the body to eliminate heat through radiation. Humidity, once humidity again reaches 75%, evaporation ceases to occur, so the body cannot eliminate body heat through evaporation. Activity, exercise, strenuous activity in hot, humid environments puts an individual at risk for this. Age, very young and elderly patients don't have the same abilities as normal, healthy adults to eliminate that body heat. Medical conditions like heart disease, lung disease, diabetes, obesity, fever, and fatigue all limit the body's ability to eliminate excessive heat effectively. And drugs, alcohol, cocaine, barbiturates, hallucinogens, and other drugs affect the body's ability to eliminate heat. Some stimulants can actually increase body temperature by increasing the body's metabolic rate. Sorry, that would be like I gotta think of it.
That'd be like caffeine and whatnot, yeah?
What's that?
That would be like caffeine or coffee, right?
Yeah, that could be one. Yeah, any kind of stimulants that has caffeine in it. The one I was thinking of is excited delirium is where they start to their body temperature increases. They start to like strip down, get naked, start running around. Their metabolic rate is super high. So with any emergency, scene size up, put on your appropriate precautions. While we're approaching the patient, observe the patient's location. If the patient is still in the hot environment or have they been removed, how long were they out in that hot environment? What is the temperature and humidity in that environment? And that stuff you can put in your report. Um, how long were they in that environment? The longer they're exposed, the more serious their condition is going to be. So some signs and symptoms that we're going to see, again, just like cold, heat-related emergencies are a progressive condition. So starting to recognize some of these signs and symptoms like weakness, exhaustion, muscle cramps, especially in the arms, the legs, and the abdominal area, dizziness, faintness, rapid pulse rate, headache, rapid pulse. Again, that's some of your signs of shock, right? They could have seizures, be nausea or vomit, alter mental status, including being unresponsive. And then skin condition could be moist, normal to cool in temperature with heat exhaustion or heat cramps. When they get towards that heat stroke, they're going to be hot and dry. So if they're still moist, normal to cool in temperature, they probably just have exhaustion or heat cramps. But if their skin is hot and moist or hot and dry, um, then we're leaning towards the heat stroke because they've lost their ability to sweat. So first, remove the patient from that hot environment. Administer oxygen to the patient via non-rebreather mask if the breathing is adequate. If they're not breathing adequately, get your bag valve mask out. Hook that up to high concentration oxygen, which is 15 liters per minute. Cool the patient by first removing any restrictive clothing. Additional steps to cool the patient depend on the signs and symptoms that you're being presented with. If the patient has moist, pale to normal skin, fan the surface of the skin while we mist them with water. If the patient's skin is hot and dry or hot and moist, we're going to apply cold packs to the same spots we're putting hot packs, so the neck, the armpits, and the groin. Keep the skin wet and aggressively fan the patient. We're not going to allow them to fan themselves. We don't want them to exert themselves at all. If the patient begins to shiver, we're going to stop all cooling processes until the shivering stops. And then position the patient supine with their legs elevated 8 to 12 inches. We want to monitor their vital signs frequently, document any findings, and pass it along to the ambulance coming in. So that's heat. Submersion emergencies. So we're going to spend time around water. We all live in northern Minnesota. Recreational activities. In some cases, people work in and around water. So as a first responder, we're going to be called to emergencies involving submersions of a patient. People have bathtubs, you can submerge in there. Drowning, I think that talks about it. Yeah, so drowning, this is defined as the process of respiratory impairment, like coughing, shortness of breath, or respiratory arrest, that results from submersion in a liquid. So the difference between immersion and submersion is immersion, you're in the water. Submersion, as soon as you have that SUB part of it, is your head actually goes underwater. So in the past, responders used the term near drowning. I'm sure you guys have heard of that. This term was used in reference to patients who were submerged but didn't die. That term is no longer being used. However, you may still hear it out in the field. In 2005, the CDC, Center for Disease Control, reported 3,500 unintentional drownings and additional 710 deaths from drownings and other causes in boat-related incidences. Only a small percentage of the patients had significant amount of water in their lungs when they were autopsied. The actual cause of death was suffocation or deprivation or of their air exchange. So when a person is submerged, we have a reflex that causes our airway to close and prevents water from being aspirated into our lungs. But what else can also not get into our lungs? Air, right? Um, Many contributing factors to drowning and water-related instances are preventable. Some of the main ones, children under the age of 1 year most often drown in bathtubs, buckets, or toilets. Children 1 to 4 years of age often drown in residential swimming pools. In most cases, children were left unsupervised for less than 5 minutes. The percentage of drownings that occur in natural water settings like lakes, rivers, and oceans increases with age. Most drownings in people over 15 years of age in natural water settings. In 2006, I know this is an old stat, but the U.S. Coast Guard reported that 90% of all boaters who drowned were not wearing their life jackets. Alcohol is involved in up to 50% of adolescent and adult deaths associated with recreational water activities, and alcohol is involved in 1 of 5 reported boating fatalities. Drowning is the most common cause of unintentional death for people with seizure disorders. This often occurs in the bathtub. So we got to think about that as well. If the patient is responsive and able to assist in the rescue, the safest method for rescue may be to throw the patient a rope or reach out to them with a pole. And we're going to talk about this water rescue technique that it's not an acronym, but it's called Talk, Reach, Throw, Row, Go, Helo. So we'll talk about that in a few slides coming up. But it's always going to be shore-based rescue for what you guys are doing, unless you're trained in water rescue. If the patient is on the surface of the water, they're going to be easier to rescue than if they're submerged or under the water, obviously. If the patient is submerged, they're more likely going to require immediate basic life support when they come back up. Hopefully it's not too late. Those patients are difficult to locate. If the patient has a traumatic injury, we may need to extricate them from the water before we start care. Keep in mind that when we're talking about water rescue, your safety, I guess, again, is precedent over everything. So if you're not trained in some of this stuff, you're doing shore-based stuff, which I'll talk about. So after your safety has been ensured, consider patient condition, water conditions, and resources that you have available to you. You can call in your local rescue team, your fire department, the ambulance, fire department, first responders might be able to do this in some areas, St. Louis County Search and Rescue as well. So get some of those resources coming to you. Water conditions, some very important aspect to consider as well. Visibility, this is how deep you can see in the water. I know we have good clear water up here for the most part, but some areas aren't. Can you see a potential hazard in or around that water, under the water? Can you see the patient in or under the water? If you know where the patient was and they went down, make sure you know where that their last known location was, because usually they're within about 10 feet of that. Temperature for cold water drownings. Remember that the patient is not dead until they're warm and dead. Initiate resuscitation and continue until the patient is rewarmed at the hospital. I think it was a kid, the longest somebody was underwater, cold water rescue. The kid was submerged for like just over 2 hours under the water and came back neurologically intact, normal kid. So we're always going to resuscitate people. For moving water, will the location of the patient change? Is it safe for you to enter the water? I'm going to say no, unless you've been trained to do that. When considering a moving water rescue, looking for hazards like strainers, which are obstructions that allow water to pass through them, but they're small enough to catch us or larger objects, so we can't get through. Fixed obstructions and movable objects like bridge abutments, large rocks that we can get pinned against. Holes created from moving current, where water recirculates and traps the patient and rescuer. We don't want that to happen. Low head dams, like in the picture up here, places that water flows over man-made or natural dams and recirculates at the bottom. So people are just going to recirculate here. Unless you get all the way down, you'll eventually be pushed out, but a lot of times you're just circling. Water depth, is the water shallow enough for you to stand at the bottom? Is there additional equipment you can use to reach the patient? And other hazards out there, hazardous materials that are present. Are there obstructions like fallen trees or debris in the water? What are you dealing with? So don't go in unless you're comfortable going in and trained to do so. Consider the resources you have available to plan your best course of action here. Number of personnel and their abilities. How many rescuers are on scene? Can they swim? Are they trained in water rescue? Equipment. Do you have the proper equipment to safely perform that? Like a life jacket. You should at least have one of those on. Specialized teams. So again, we do have specialized teams up here that you can call in. They just take a little bit of time to get there. Unfortunately, there have been many instances of well-intended rescuers who have been injured or lost their lives by attempting to perform a water rescue without the appropriate safety equipment. So always remember your safety comes first. General guidelines for water rescue. It's in here, it's reach, throw, untow, row, and go. So I always say talk first, talk to your patient, try to see if they can self-rescue. Never attempt a water rescue unless you're a good swimmer, specifically trained in water rescue, you're wearing a life jacket, and you're accompanied by another rescuer to be tied off. So if those criteria are met, you can do that. Otherwise, shore-based rescue. So we have the talking to them, try to get them to self-rescue. Reach, hold on an object out for the patient to grab. Maintain a solid footing while extending the object so that you don't slip into the water yourself. Throw, if the patient is too far out, is there something that floats that you can throw to them? Like there's a lot of things that float. Coolers float, tires float. What do you have that floats you can throw to them so they at least have something to grab onto? If you tie that off to something, you can then pull them in or tow them back to safety. Row, if the patient's too far out to reach, to throw an object from shore, we can get into a boat and get closer to them and do these same things. And then go, if reaching, throwing, and rowing are not possible, we would swim out to the patient. But you have to be a strong swimmer, trained to do that, wearing a life jacket, accompanied by somebody else, and that is our last resort. All right, so general signs and symptoms if somebody is in a submersion event. If the patient swallowed water during a submersion, they may be actively vomiting the swallowed water. The patient aspirated water, which means it's going into their lungs, or was without oxygen for a length of time. They may be coughing or having difficulty breathing. Patients who have either aspirated large amounts of water or deprived of oxygen for an extended period of time could go into respiratory or cardiac arrest. So be cautious for that. Maybe get your bag valve mask ready, get your AED ready, just in case they go into respiratory arrest or cardiac arrest. So any type of injury that can occur on land can also occur in the water. If the mechanism of injury leads you to suspect a spinal injury, like diving, or you see something like the mechanism, like a boating injury, or they're on a personal watercraft, something like that, we can consider C-spine if we need to. So we would initiate appropriate manual stabilization techniques, maintain them throughout the patient contact. With scene size up, perform an appropriate assessment of the scene, take all your necessary precautions. Activate EMS, ensure that assistance has been called, and provide details of the emergency so dispatch can send people your way that need to come. Assess their airway, be prepared to suction the airway or manually open the airway for patients who are unresponsive. Assess their breathing, ensure adequate breathing, and provide ventilation with a bag valve mask when it's indicated. Remove the patient from the water using the talk, reach, throw, row, go strategy. Position the patient. If you suspect a spinal injury, initiate manual stabilization of the spine. We can backboard them in the water, get them into a boat or back to shore. If we're not suspecting spinal injury, we're going to place them in the recovery position on their side. Assess their circulation, so looking at a pulse, provide CPR if needed. Administer oxygen, high flow, non-rebreather if they're breathing adequately, which would be 15 liters again, or a bag valve mask if they're breathing inadequately, hooked up to 15 liters per minute. Monitor the patient, monitor for signs of hypothermia, treat appropriately, monitor their vital signs, ABCs, all of that. Document your findings, pass it along to EMS. Just keep these guys are typically unstable, so every 5 minutes you'd want to just keep reassessing them in case something's changing. All right, the term used to describe all the physical and chemical changes that occur in the body is called metabolism. The term used to describe a generalized cooling, that's our hypothermia. A severe heat emergency that develops into uncontrolled rise of body temperature. This is called hyperthermia. And then in what order are the steps? So we would want to talk, reach, throw, row, go. And then helo is the other option because a lot of times we would want to get aeromedical coming in these circumstances. All right, stop my screen share. Any questions on that one?
So far, so good.
Okay. Let me get rid of 23 here. Let me share 24. All right, so switching gears here. Now we're on kids. So this chapter is obstetrics and neonatal care, and then we'll talk about pediatrics coming up here. So this one is anatomy of pregnancy, stages of labor, assisting in childbirth, caring for the newborn, the mother, and then complications of delivery and pregnancy. So some of the stuff we've talked about in like medical, like when I talked about eclampsia and that type of stuff, we're going to talk about more here. So from time to time, you may respond to a call where child birth is or delivery is imminent, or where childbirth has maybe just occurred. In these rare cases, you're going to deliver the child or care for the child that was just delivered. Most of the time, it's uneventful. However, childbirth is painful for the mother and stressful for the family, especially if they're doing it at home or in a car. It can also lead to very anxious moments for you because a lot of people are like, well, I don't want to ever deliver a baby. Each of these responses is anticipated and is appropriate for you to believe in. So this chapter is going to discuss transport decisions, normal delivery and post-delivery care, managing complications associated with pregnancy and childbirth, assessing and caring for the newborn, and providing newborn resuscitation for the rare instances when needed. In most cases, it will go smoothly. Remember that once the baby is delivered, we have two patients, the mother and the baby. So anatomy of pregnancy. So let's look at the different structures that play a role in providing a safe place for the baby to grow, the structures responsible for providing nutrition to the baby, and the structures that could come into play during delivery. So we have the uterus. The uterus is an organ that houses the fetus during development. A special arrangement of smooth muscles and blood vessels in the uterus allows for expansion as the fetus grows during pregnancy and provides contractions necessary for labor and delivery. After delivery, the uterus allows for rapid contractions, which helps constrict blood vessels and prevent excessive bleeding in the mother. During the course of pregnancy, the walls of the uterus become thin. The cervix, which is the neck of the uterus that connects with the vagina, contains a mucus plug that is discharged during labor. Expulsion of the mucus plug is known as the bloody show and appears as vaginal discharge that is pink-tinged mucus. The amniotic sac, this is a sac filled with fluid in which the fetus floats. It protects and insulates the baby until they are delivered. The fluid varies, but is generally between 500 and 1,000 milliliters. So it's like half an Nalgene to a Nalgene. During labor, the sac is usually forced against the cervix, causing the cervix to dilate in preparation for delivery. The sac, that amniotic sac, usually bursts during delivery or during labor. This results in a gush of fluid from the vagina, and this is where the patient may say their water broke. The birth canal consists of a cervix and the vagina. Vagina is about 8 to 12 centimeters or 3 to 5 inches in length. It originates at the cervix and extends to outside of the vaginal opening. A smooth muscle layer gently stretches during childbirth to allow passage of the infant. The placenta, which is up here, is a disc-shaped organ that develops during pregnancy on the inner liner of the uterus. It's rich in blood vessels. It provides nourishment and oxygen to the fetus from the mother's blood. The placenta also absorbs waste from the fetus and sends it into the mother's bloodstream to be eliminated. The mother's blood and the fetus blood never mix. The placenta also produces hormones that sustain the pregnancy. After the delivery of the baby, the placenta separates from the uterine wall and delivers as the afterbirth, which usually weighs about a pound. The umbilical cord is the baby's lifeline. It's an extension of the placenta through which the fetus receives its nourishment. The umbilical cord contains one vein and two arteries. The vein carries oxygenated blood to the fetus, right? So that's opposite of kind of us, while the arteries carry deoxygenated blood from the fetus back to the placenta. When the baby is born, the cord looks like a rope about 22 inches long and about an inch in diameter. So anatomy, full-term pregnancy is 40 weeks. Toward the end of the pregnancy, the baby is usually in a head-down position, bringing the uterus down and forward. A lot of times mothers can feel this. They can feel the difference, and they maybe say like the baby has dropped. This position is most favorable for the baby's passage through the birth canal. We like to hear that the baby dropped. Labor is a term that refers to the process of childbirth. It consists of contractions of the uterine wall, which push the baby into the birth canal and later aid in delivery of the placenta. Normal labor is divided into 3 stages, which we will talk about coming up here. And the length of each stage varies greatly in different women and deliveries. It's not all set at a certain number. So the stages of labor, during the first and longest stage of labor, the cervix becomes fully dilated. This allows the baby's head to pass from the uterus into the birth canal. Through uterine contractions, the cervix gradually stretches and thins until the opening is large enough for the baby to pass through it, usually around 10 centimeters. The contractions of labor usually begin as an aching pain in the small of the back. In short time, the pains become cramp-like in the lower abdominal area. These pains reoccur at regular intervals, each one lasting from 30 to 60 seconds. Early on, the contractions are about 10 to 20 minutes apart and not very painful. Appearance of the mucus plug may occur before or during this stage of labor. The amniotic sac may rupture, resulting in a gush of fluid from the vagina. That's the water breaking. So that's the first stage, dilation of the cervix. Stage 2 is expulsion, actually having the child. So during the second stage of labor, the baby moves through the birth canal and is born. Contractions are closer and they last approximately 45 to 90 seconds each. As the baby moves downward, the mother feels considerable pressure in her rectum, like feeling like they're going to have a bowel movement or having to poop, combined with the urge to bear down and push. When the mother has this sensation, she should lie down and prepare for delivery. The tightening and bearing down sensations will become stronger and more frequent. At this time, the mother will have an uncontrollable urge to push and should do so. There will probably be some bloody discharge from the vagina at this point. Soon after, the baby's head will be visible at the opening of the vagina. This is called crowning, when you can see the top of their head. Once the head is delivered, the shoulders and the rest of the body typically follow. And then stage 3, delivery of the placenta. During the third stage, the placenta separates from the uterine wall and is usually expelled from the uterus through the birth canal. This may not happen immediately after the baby is born, but we'll talk about that. Usually it's within about 10 or 15 minutes. So us assisting in childbirth, get your OB kit out. Delivery of a child in an emergency outside of a hospital is pretty rare. When you are called to a scene where delivery is imminent, remain calm, reassure the mother, Make sure that you have your OB kit, and keep in mind that you're simply assisting in a natural process. You're not tugging this baby out. And then once that baby comes out, you have two patients, the mother and the baby. Identifying an imminent delivery is an important goal in assessing a woman in labor. Supine hypotension syndrome can occur when a woman is in her third trimester and lying on their back. The weight of that fetus compresses the vena cava, that big vein in your abdominal area, which decreases the amount of blood returning to the heart. That results in a drop in cardiac output and subsequently hypotension or low blood pressure. A delivery requires PPE beyond standard precautions. Don't just think I'm going to put on gloves and glasses and I'm going to go in. So you're going to be gowning up. This is going to be, I call it a hazmat situation. During crowning, as a first responder, we should gently place the gloved hand on the top of the baby's head to prevent an explosive delivery. And we'll talk about some of this other stuff coming up. So assisting in this labor process. So perform a scene size up, primary assessment, as we would any other call. Determine if delivery is imminent by the following steps. If the baby's crowning, so if the baby's head is visible at the opening of the vagina, we want to immediately prepare for delivery. If the baby is not crowning, we're going to place your hand on the mother's abdominal area, feel for tightening and relaxing of the uterus. Those are contractions. We're going to time the contractions in seconds from the moment the uterus first tightens until it completely relaxes. And we're going to time the intervals in minutes from the start of one contraction to the start of the next. So the contractions themselves is from when it first starts till it stops. So is it 2 minutes? Did it last for 90 seconds? Did it last for 5 minutes? And then the time of the intervals is when one starts until the next one starts. That's your time interval between how long you have. If the time between contractions is more than 5 minutes, we probably have time to get them to the hospital. If the contractions are 2 minutes apart, we're gonna have to make that decision. If it's less than 2 minutes apart, you're probably having that baby right where you're at. So timing contractions is not a super reliable method of predicting when a baby is gonna be delivered because people are different. Although in general, it's true that the time of contraction shortens as the birth draws near, being prepared for exceptions, but maybe this is somebody's fourth kid. They usually come out a little quicker after the first couple. Make a decision. If contractions are between 2 and 5 minutes apart, we're going to make a decision about whether or not to transport the mother based on have they had a baby before. Subsequently, mothers who have delivered before tend to be in labor for shorter periods of time. When is their due date? If the baby's premature, they may need care beyond of what we can provide, so we want to get them to the hospital. Have they been receiving prenatal care? Are they having more than one baby? Are they having 2 or 3 or 5? Yikes. Only have one OB kit, right? Have they had any complications with their pregnancy? So remain calm, show confidence, show support, ask some questions, make that decision depending on contraction times, the time interval. We can also ask them if their water's broken. If it was, what color is it? And I'll talk about why that is important. Do they feel the sensation of having to have a bowel movement? Don't let the mother go sit in the toilet. They'll probably have that baby in the toilet. If that is a sensation, the baby is positioned in the birth canal and is going to be born pretty soon. Do you feel like the baby's ready to be born? If they're answering yes to these, we should be probably staying put. If you feel that delivery is going to be soon, OB kit, standard precautions, put your gown on, determine if there's crowning. You're going to have to look. So put the mother on their back with their knees bent, legs spread. If you have a female partner, that would be best. Inspect the vaginal area, but don't touch it except during delivery and if possible with another EMS person present. If you see bulging in the vaginal area and either the head or other part of the baby is visible, prepare for delivery. Though rare, a limb or umbilical cord may be the presenting part, and we'll talk about those under complications. If the transporting ambulance has not yet arrived, update them on what's going on. Tell them that you're preparing for immediate delivery before transport and identify the presenting part to them. If it's the head, the butt, the feet, an arm, umbilical cord, what it is coming out. We'll talk about those in some pictures coming up. Be alert to the possibility of supine hypotension syndrome, like I mentioned earlier. That is a condition, again, that can occur during the last few months of pregnancy when the weight of the uterus and the baby become pretty significant. Combined weight of the uterus and the fetus compress that inferior vena cava, kind of in our like chest area. That pressure on the vessel reduces the amount of blood flow returning to the heart, results in hypotension or low blood pressure, which is the reduction of the circulation to the body. To avoid this, we want to position our patient in a sitting position or on their left side. I know recovery positions, I told you, it doesn't matter. This is the only case it does. If you have a pregnant lady, you would always want to put them on their left side in that recovery position. This prevents the uterus from compressing the vena cava. If the pregnant patient is a trauma patient and they're immobilized to a long backboard, we would want to prop the backboard up or tilt the backboard to relieve pressure on the uterus and the vena cava to the left side. Just a little bit, like a couple inches is fine. Reassure and encourage the mother by telling her that you are going to be there to assist her through this delivery process. Get the OB kit. Materials used should be as sterile as possible, or at least as clean as possible. At a minimum, in your OB kit, you're going to have sheets and towels and a receiving blanket. You're going to have some 4-inch gauze pads, sanitary napkins, suction, bulb syringes like up here, scissors so you can cut the umbilical cord. You're going to have these clamps right here to tie the umbilical cord, germicidal wipes, plastic bag so you can put the placenta in here and bring it with you or send it with them, sterile gloves, sterile gown. This is a Chuck's pad that you can put underneath the mom's butt. BVM, I would get your pediatric bag out if you have one, or get some like your bag valve mask out. It's just some resuscitation equipment just in case, just to be prepared. Don your equipment and let the party begin, I guess, huh? So help the mother relax. Just be there to support them. Place towel under their butt. Allow a position of comfort. Elevate the mom's hips. Create as sterile field as possible. If there's people that don't need to be in that room, get them out. Have her put her chin to her chest while they're bearing down, and be prepared to provide care. Fun pictures. When delivering the baby, place the palm of your hand gently on the baby's head. Avoid the fontanelles. Remember, there's a fontanelle posterior and anterior, so there's 2 fontanelles. We don't want to push in on those. The soft spots. When the head crowns, we're going to gently apply pressure to avoid explosive delivery. If the amniotic sac has not broken, that's where we're going to tear it open with a finger and push it away from the infant's mouth and their nose. The baby can safely inhale clear amniotic fluid, but if there's a greenish or brownish fluid, that's what they call meconium staining. This is that the baby has had a bowel movement prior to being born, and if they inhale that, it can cause pneumonia. So the baby's stressed to start with. So the presence of meconium is a serious condition indicating fetal distress. If that is present, the greenish or brownish fluid instead of clear, immediately clean the baby's mouth and nose as soon as they're delivered. Suction the mouth first, then the nose. Ensure ALS backups en route, because they might aspirate some of that, and it can lead to pneumonia, and that can lead to death, unfortunately. When the head delivers, determine the position of the umbilical cord. If the cord is around the baby's neck, we're going to put 2 gloved fingers under the cord and try to slip it over the baby's head. If the cord cannot be removed, we're going to have to clamp it off and cut it. Support the baby's head as it appears from the vaginal opening by placing one hand beneath it. In most cases, the head is delivered, the baby is going to be face down and naturally rotate up as their shoulders kind of pop out. Support the baby with both hands as the rest of the body is delivered. Once the shoulders are delivered, the rest of the body usually rapidly delivers. Be prepared to catch the baby. Do not drop the baby. They are slippery when they're delivered. Handle them gently. Never pull them from the vagina. Let that happen naturally. Once the baby is out, position the baby at the level of the mother's vagina until the umbilical cord is clamped and cut. Make sure they're level. Assess the baby's breathing. If they're actively breathing without obstruction, move on to routine care. If they have any obstructions to their breathing, we can suction their airway. Note the time of delivery for their birth certificate. If the mother's bleeding is common after childbirth, so I'll talk about ways to help with that, and then be prepared to the placenta is going to deliver soon after this, so be prepared that's coming out as well. So the newborn, once the baby's out, dry the newborn and wrap them in clean, warm blanket. Lay them down on their side with their head slightly lower than their trunk to allow fluids to drain from the airway. Continue to assess the baby's airway. If obstructions are present, we can use the bulb syringe to suction. However, suctioning can cause the baby's heart rate to slow and should only be performed if we need to do that. If the newborn is not breathing, provide tactile stimulation by rubbing their back or slapping the soles of their feet. To prevent newborn hypothermia, replace wet blankets with dry ones, clean and dry. Keep the newborn's head covered. A lot of these OB kits are also coming with little hats too for the babies and emergency blankets to wrap them and keep them warm. Just keep them warm until they are going to be transported. The process of drying the baby usually stimulates breathing. If it does not, provide tactile stimulation by rubbing the baby's back or gently slapping the soles of their feet. Again, we can apply blow-by oxygen if the baby's not breathing well. That's this picture right here. So it's not actually on them, but it's blowing into their face. Perform bag valve mask ventilations if you have a newborn that's not breathing after drying, warming, and tactile stimulation, or if they're gasping. Or if their pulse is less than 100 beats per minute, we're going to bag valve mask them, try to get that up. The recommended rate of ventilations for a newborn is 30 to 60 breaths per minute. So if breathing and pulse are absent, or if the heart rate is less than 60 beats per minute, we're actually going to start CPR with compressions at a rate of 120 per minute. And the ratio of compressions to ventilations is 3 to 1. So we're going to do 3 compressions, 1 ventilation, 3 compressions, 1 ventilation until that comes up. The most common complication of auto-hospital delivery is that the newborn becomes too cold. Prevention of newborn hypothermia is the most next crucial part of newborn aftercare. Ensures adequate breathing and heart rate after that. So steps to prevent hypothermia, just get those wet blankets off, remove them put dry ones on, keep their head covered, and keep them in a warm environment. Preventing hypothermia. Cutting the umbilical cord, though it's not necessarily time sensitive or absolutely imperative, we should eventually cut the cord. We want to wait at least 1 to 3 minutes before doing so. The cord is going to pulsate, so we want to wait until it stops pulsating. So wait till it stops pulsating. We're going to place a clamp or a tie at least 6 inches from the baby, and then place the second clamp or tie 3 inches away from that. Sometimes the 6 inches that we give them, if the baby needs to be in like the NICU or something like that, instead of starting an IV on the baby, they'll use this cord part to do that. So don't just cut right by the baby. Give it about 6 inches and then another 3 inches after that. So they're going to clamp, then you're going to cut between. Caring for the mother. Further care for the mother usually includes emotional support, assisting in delivery of the placenta, and controlling any vaginal bleeding that she might have. Usually the placenta delivers between 10 and 30 minutes after the baby. It's usually preceded by a lengthening of the umbilical cord and a sudden gush of blood. Occasionally, bleeding can be excessive after delivery. Breastfeeding and uterine massage can help with this. We also want to consider the possibility that the mother might have shock or might be in shock if they are bleeding excessively. So treating them for shock, high flow oxygen, keeping them warm, laying them on their back, immediate transports. So after the placenta, after the delivery of the baby, observe the delivery of the placenta. When it begins to separate from the uterine wall, the umbilical cord will appear longer. The uterus will contract and feel like a hard grapefruit-sized ball. Encourage the mother to bear down as the uterus contracts. The placenta usually delivers within 10 minutes, almost always within 30 minutes after the delivery of the infant. Normally, some bleeding will occur as the placenta separates. When the placenta appears, slowly and gently guide it from the vagina. Don't pull on it and facilitate delivery. Let that happen naturally again. After the delivery of the placenta, check the mother for vaginal bleeding. A loss of up to about 500 milliliters of blood is normal after delivery and is usually well tolerated by the mother. We can place 2 sanitary napkins, they look like the pads, over the opening of the vagina to absorb slow bleeding if it is present. If the mother plans to breastfeed the infant, we want to encourage the mother to begin that because breastfeeding is going to help the uterus contract, decrease the size of the uterus, and help stop the bleeding. So that's a good thing. If bleeding is excessive after delivery, we want to assess and treat the mother for shock and arrange for immediate transport, high flow oxygen, lay them on their back, keep them warm. We can massage the uterus by cupping your hand around the contracted uterus and massage in a circular motion. Continue to massage until the bleeding has stopped. This can cause pain in the mother. However, if the bleeding is severe, it's an essential treatment step, and we want to alert EMS of what's going on. So that would be kind of like a normal delivery. Sounds super fun, right? Complications of a delivery. So the umbilical cord, a prolapsed umbilical cord. The umbilical cord may come out of the birth canal and be compressed against the bones of the mother's pelvis by the baby's head. This is an extremely urgent situation because the baby receives oxygen supply from the placenta through that cord. So if this happens and you're seeing the umbilical cord first, we want to place the mother on their left side if possible, elevate her hips and legs with a pillow or blanket, have her draw her knees to her chest and hold them there, administer high flow oxygen. And this is where you're going to be part of the unit now. With your gloved hand, gently apply pressure to the baby's head, pushing the baby's head away from the compressed cord so that the cord pulsates and the baby's getting oxygen. Otherwise, the baby's not getting oxygen. So you're going to be stuck there until you get to the hospital, or somebody can take over doing that. Cover the cord with a moist, sterile dressing, but don't push the cord back in. We're simply putting our gloved fingers in and pushing the baby a little bit to get the cord to start pulsating again. And that's how we're going to transport. So place the mother on their side, elevate the mother's hips, knees up, high flow to push the baby's head away from the cord, and don't attempt to push the cord back in. And we're going to wrap it in moist, sterile dressing. If you have a breech birth, the baby's feet or butt deliver first. Whenever possible, we want to transport the mother to the hospital for a breech birth. Things can be complicated. If transport is not possible, we can prepare for delivery in the field. The baby's legs are delivered. When the baby's legs are delivered, we're going to place the palm of one hand on the baby's trunk, like in the picture, allowing the legs to dangle astride your arms. Then let the head be delivered. Hopefully the head comes out. If the head does not deliver within 3 minutes, that baby's going to suffocate or is in danger of suffocation because the compressed cord. So if it's not within 3 minutes, we want to clear the baby's face away to create an airway by placing our index and middle finger alongside the infant's face. So we want to put index finger, middle finger, whatever you got, opening an airway up for this baby. And again, you're going to be stuck there in that position, being able so the baby can breathe. So you're going to be kind of a unit, just like you were with the umbilical cord. We're going to form an airway by pushing the vaginal wall away from the baby's face until the head is delivered. Yeah, so you're going to be stuck like this till you get to the hospital or somebody takes over in that position and goes to the hospital with them as a unit. Limb presentation is when you have either an arm or a leg present from the birth canal first. Normal delivery, even by a physician, is usually not possible in the field or in the hospital setting. This baby is usually going to be delivered through a cesarean or a C-section. With limb presentation, we want to transport the mother immediately to the hospital. Any delay can be fatal to the baby. We're never going to pull on the limb, right? For multiple births, if you have twins delivered the same way as a single birth, in fact, twins are smaller, so delivery could be easier. The mother may not be aware that she's carrying twins. Usually most people are, but we should suspect twins if the abdominal area is still very large after delivery of one baby. The baby's size is not in proportion to the size of the mother's abdominal area, or strong contractions begin about 10 minutes after delivery of one baby. The second baby is usually born within minutes of the first. When delivering twins, we want to clamp and cut the umbilical cord after the first baby is born. About a third of second twins are born breech. If the second twin is not born within 10 minutes, we should start transport. After the second baby is born, expect a normal delivery of the placenta or placentas. Identical twins share one placenta, and fraternal twins actually have two separate placentas. So you might have two placentas that come out. Premature birth. So if a woman gives birth before completing the 36th week of pregnancy, or if the baby weighs less than 5.5 pounds on delivery, they are considered premature. Babies are usually smaller and their heads are proportionally larger in comparison to the rest of their body. Because they're very vulnerable to infection, we want to take special care to keep them warm, keep their airway clear of fluids with gentle suction, and prevent bleeding from the umbilical cord by clamping it securely. A premature infant cannot tolerate even a very small amount of blood loss. Don't let anybody breathe in the baby's face. Do everything you can do to prevent contamination. Okay, complications of pregnancy. Preeclampsia. So preeclampsia affects between 5 and 8% of pregnant women. Signs and symptoms of this are hypertension, swelling of the face and the extremities, headache, nausea or vomiting, and abnormal weight gain. Some women will develop a more serious condition called eclampsia. Eclampsia has the same signs and symptoms of preeclampsia, but it includes a seizure. So if they have a seizure, they're right into eclampsia. So eclampsia threatens the life of both the mother and the fetus. Treatment of seizures due to eclampsia is the same you would any other seizure patient. So clear the area, make sure they don't harm themselves, and it would be the post seizure, like oxygen, put them on their side, all of that stuff. Just want to protect the mother and the fetus from any trauma during that seizure. Vaginal bleeding. There are many reasons for vaginal bleeding. However, women who are pregnant in particular is a concern. We'll talk about each one of these. So some of the causes of this, spontaneous abortion, ectopic pregnancy, placenta previa, and abruptial placenta. So let's talk about spontaneous abortion. This occurs naturally before the 20th week of pregnancy. This is sometimes called a miscarriage. So with this, they're going to have heavy vaginal bleeding, lower abdominal pain similar to menstrual cramps or labor contractions, and passage of tissue from the vagina. Emergency care, what we do, immediate transfer to the hospital. We can, if there's any tissue that has been passed, we want to put that in a bag and bring it with us or send it with EMS so the doctor can evaluate that. Ectopic pregnancy. In a normal pregnancy, a fertilized ovum is implanted into the uterus where it should be. In an ectopic pregnancy, a fertilized ovum is actually implanted outside of the uterus, most often on a fallopian or in a fallopian tube. This is a serious emergency. The expanding fertilized ovum leads to rupture of that fallopian tube and severe internal bleeding. This is the leading cause of death in pregnant women in their first trimester of pregnancy. So some signs and symptoms with this: a sudden sharp pain, tender bloated abdominal area, a vaginal spotting or bleeding, missed menstrual periods, and signs of shock. For this, arrange for immediate transport and treat them for shock. If we're suspecting any woman in a childbearing age with those signs and symptoms, with these signs and symptoms, we should be thinking ectopic. A lot of times people miss that, and it's very deadly. Placenta previa. This is when the placenta is positioned too low in the uterus during pregnancy. When the cervix dilates, the placenta enters into the birth canal first, and it begins to bleed and is pushed into the birth canal, and that puts the mother and the baby both in danger. So this one, it could be severe, painless bleeding, signs of shock. So again, there's not much we can do for some of this stuff. It's kind of package them up for immediate transport and treat them for shock. Lay them on their left side, high flow oxygen. Package them for immediate transport. Keep them warm. And then abruptial placenta. This is a leading cause of fetal death after blunt trauma. This is why if somebody gets into a car accident or falls, they'll go get checked out. This is a life-threatening condition for both the baby and the mother. Causes include toxemia and trauma. Whatever the cause, the normal implanted placenta begins to separate from the uterine wall during the last 3 months of pregnancy. Bleeding begins, but is often behind the placenta, so you're not aware that they're bleeding. And the baby doesn't get enough oxygen, so they want to go make sure the baby's good. So if they have severe abdominal bleeding or severe abdominal pain, moderate bleeding, or rigid abdomen, and signs of shock, that is some of the stuff we're looking for with the subruptural placenta. Typically, this is, again, toxemia, so drugs and alcohol and trauma. So again, immediate transport, treat for shock. All right, so uterus, this is the organ that contains the developing fetus. Cervix is the neck of the uterus. The bloody show is the plug of mucus that is discharged during labor. Placenta is a disc-shaped organ on the inner lining of the uterus that provides nourishment and oxygen to the developing fetus. Afterbirth is the placenta after it separates from the uterine wall and delivers. Umbilical cord is the extension of the placenta through which the developing fetus receives nourishment while in the uterus. The amniotic sac is a sac of fluid in which the developing fetus floats, also called the bag of water. Birth canal is an anatomical passage made up of the cervix and the vagina. Meconium staining, this is that greenish or brownish color to the amniotic fluid, meaning the new unborn infant had a bowel movement, which means fetal distress. So we want to make sure that they're not breathing that in. So we would suction first. Preeclampsia is a complication in pregnancy when the women retain large amount of fluid and have high blood pressure. Eclampsia is a severe complication of pregnancy that produces seizures and possibly a coma. Miscarriage is a natural loss of pregnancy, usually before the 20th week, also called a spontaneous abortion. Fallopian tube, this is one of the two tubes or ducts that extend up from the uterus to position near an ovary. The ovary is one of the two almond-shaped glands in the female that produces the reproductive cell or the ovum. The ovum is our reproductive cell or the egg. Fontanelle is that soft spot between the cranial bones of the skull of an infant. Remember, there's two. There's an anterior one in front and a posterior one back. All right, so the bag of water refers to the amniotic sac. How many weeks is a full-term pregnancy? 40. Okay, good. Questions on babies. Those are fun pictures. Always a good time.
No, I'm very good. I'm pretty sure we're good.
It's always fun to teach this part to 18-year-olds in my EMR class at school. Their faces say it all. All right, so I'm gonna just look ahead at next week and see how long these are. Because, okay, so here's the deal. Let me get rid of this on my screen. So sharing, nope, say sharing is caring, but I don't have what I need on my screen right now. Sharing this. Throw out your opinions at me. So today we have 23, 24, and 25 are a little bit lengthy, and I get that. 26 and 27 are like 35 slides or less. So we're talking like maybe less than an hour next week. Do you guys want to throw on pediatrics to this one for next week and do pediatric, like young people, old people, and special populations? How is that sounding to people? Opinions?